I am Elena Ratner. I'm one of the GYN oncologists at Yale, and we are so excited to have you with us today to discuss issues of survivorship, sexuality, and intimacy, all issues that we find to be of paramount importance. I would like to introduce my colleagues, Mary Jane Minkin, who is the guru of menopause and sexuality, and Johanna, who is also now the guru of sexuality and menopause, and who runs the sexuality and intimacy clinic at Yale. Dr. Minkin reminded me today that the whole reason why this program started in the first place was because many years back, I was shadowing Dr. Minkin to try to learn from her some of the wisdom of how she takes care of women with menopause and sexuality and intimacy problems. And at some point, I was amazed by the miracles that Dr. Minkin was doing with her patients in the office. And I commented to Dr. Minkin that I felt that in the world of oncology, we did not pay enough attention and we did not spend enough time dealing with those issues and helping women with these issues, or truthfully, even asking women about their concerns. And I felt that at the time, as a surgeon by practice, we spent so much time doing surgery and doing chemotherapy and doing radiation. And we were so happy that women were living and surviving, but we were forgetting how much our treatment and how much cancer itself was affecting women, and it was affecting their quality of life and these issues of survivorship. So really, in that one day with Dr. Minkin, when I realized the impact that this kind of interventions can make, we brought that back to Smilow, and that is how our practice of sexuality, intimacy, and menopause clinic was established. It was really established to help women to not just survive, but excel and exceed and live well. Everything that we try to do is to try to get women back to their normal lives. And to give them their lives back, the lives that were changed somewhat by cancer and by treatment. And that is everything that we try to do in this practice. So we're so happy today to have you all with us on this call because these issues are so important. And these issues are frequently so under-discussed and under-asked about. And we want you to know that that is just not okay, and that there's so much that can be done for this, and there's so much intervention that can be done, and there's so many different options between physical therapy and pelvic floor therapy and psychotherapy and hormonal management and naturopathic management and acupuncture, and that is the conversation that we would like to have with you today. So Dr. Minkin and Johanna will start having this conversation, and then we will certainly save a lot of time for questions so that we can make sure that all of your questions are addressed. So Dr. Minkin and Johanna, if you would like to share your slides.
Thank you, Dr. Ratner. I'm going to take some time to share my screen here, and hopefully everybody will be able to see it. And as I do that, I'll let Dr. Minkin go through some of our slides here. So hopefully you can see what I'm sharing.
Look, I can see it just fine. Everybody okay with it? We're good? Excellent. Okay, so as you all can see here, this slide, this is actually put together by Johanna, and it's a slide deck that she put together actually as an educational one for providers, but I think it's an educational one for patients as well, and I think that we selected the perfect ones for folks to learn about. So anyway, so this is for us and our friends to be discussing here. This is just a little summary about our program. The SIM stands for Sexuality, Intimacy, and Menopause, and this is the program at Smilow. And you see the little cards here that, so we have some propaganda there, and if you can pick these up at the hospital, it's online as well, as far as what we offer, and this we're going to be talking about. We truly have a multidisciplinary program. From day one, when Elena started talking about we should have a program like this, she realized not only do we want GYN oncology input, but we also wanted general gynecology to be talking about some of the menopausal and sexuality issues, but we also realized how crucial psychological issues. And from day one, we asked our psychology colleagues to join us. And so unfortunately, this last year with the pandemic, it's been a little tricky incorporating our psych colleagues with our visits, particularly ones in person because they were off site, but we certainly have them ongoing as far as relationships. The program is available to any female cancer survivor at any stage. Unfortunately, as we see it, we have 2 sessions a month. We don't have any men in our practice. We've been trying to incorporate urology. It hasn't quite worked out, but we can help find some excellent urologists as a resource if we have problems for the men as well. So next slide that we can talk about, that this is just some terminology that folks use. And of course, a survivor, as many of you know, unfortunately, it's a person who's been diagnosed with cancer, but a co-survivor is somebody who's basically caring for a loved one with cancer, it's a partnership. And we also deal with a very special group of people called previvors. And it's a term that actually folks use around the country. And I think we were one of the first places to use it. And this is basically talking about people who've had surgery to reduce his or her risk of developing cancer. For example, a classic situation is if somebody has been diagnosed as being a BRCA carrier, has fortunately not had cancer at this point, and they take out their ovaries to reduce the risk of getting ovarian cancer. That's sort of a typical term, and we refer to those young folks, and they're young folks, and that's important to emphasize in general, as previvors. And there are phases, okay, there's acute survivorship, extended and permanent survivorship, and we'll hopefully be talking about all of those issues here, albeit briefly. Okay, on our next slide, okay, got the next slide there, Johanna? Yeah, great. Just one quick thing to talk about on the previous slide, if you want to go back to the previous slide there.
Sorry.
No problem. This is a brief slide talking about the numbers of patients who are dealing with cancer. And there are unfortunately a lot of folks out there, and we have the numbers up there for 2019 up top. But as you can see, in the next 10 years, we're going to be having, we're having burgeoning numbers of folks being diagnosed with cancer. But the most important thing is we have burgeoning numbers of survivors who are doing great, and we want them leading normal lives. And that's the important thing. Okay, so can we go to our next slide here?
Yeah, and I'll just add, Dr. Minkin, that as you can see, the most common cancers that men and women survive really can have a big impact on intimate relationships. You look at the top few: prostate cancer, colon cancer, rectal cancer, breast and uterine cancers, and those really are directly impacting people's sexuality.
Absolutely. And even other things can impact sexuality, even things you might not think of impacting sexuality. And we'll try to talk about a few of those as well. And this is from the American Cancer Society, and this is related to their treatment and survivorship facts. But one thing we sort of circled here is the quality of life is extremely important for people, obviously. And its social well-being refers to the health of relationships with family members and friends, including intimacy and sexuality. So these are really important things for people to talk about and to understand, and involves both the the medical issues going on and some psychological issues going on, and why our psychology teammates are really important in this paradigm here. Okay. The next slide, this is just, and this doesn't list, this is not totally comprehensive, it's a good list, but what can contribute to sexual dysfunction, problem having sexual issues? And there are a lot of emotional factors. There's relationship stresses, unfortunately, many of you know, having dealt with the cancer diagnosis. There are issues on fertility for many young people who are affected with the diagnosis of cancer early in life. How do we deal with this? And there are issues involving body image, self-esteem, femininity, masculinity. Of course, unfortunately, many of our folks are dealing with depression. Many are people dealing with fatigue, which is both emotional and physical. And there's tremendous anxiety about sexual activity. Am I going to be okay? Will I be able to have sex? Is it going to be like it was before? Those issues are very important. And again, the unfortunate thing that can happen is areas that typically were pleasure, erogenous zones that previously gave people a good time, that people can develop some negative feelings about it. And so unfortunately, pleasure can turn to pain. And we don't want that. We want people to have pleasure and keep on having pleasure. And then of course, there's some changing roles in relationships. Can I have a sexual activity with somebody who's been my caregiver, dealing with some of my bodily functions, which may not be pleasant for me to think about or talk about. These are all issues. And again, they're all important to talk about. We're vulnerable, and people are vulnerable even without dealing with a cancer diagnosis, but many people with a cancer diagnosis are feeling much more vulnerable, and they're embarrassed about what's going on sometimes, which they shouldn't be, but they are. And there may be a fear of rejection. Is my partner going to feel about me like she or he did before? And these are real issues that folks are feeling. So there are those going on. So these are some of the multifactorial things. Then of course there are some physical activities, physical issues going on as well. Can we see the next slide then? There are hormonal changes. Okay, there can be issues related to which hormonally can decrease and manifest themselves into decreased libido. There can be issues as far as achieving arousal or orgasmic responses. Then with the guys, there can be issues involving erectile dysfunction, which can be a direct effect of surgery or radiation therapy or other emotional things going on. Then, of course, there are issues involving vaginal dryness, vulvar dryness, and pain with intercourse secondary to the dryness, or potentially scarring from surgical procedures. Then, of course, there are the fabulous things like hot flashes, that if ovarian function is taken away, women are going to be put into menopause, which can occur from surgery, or can occur from chemotherapy, or can occur from some of the hormonal therapies we use to deal with the cancer from coming back. So all of these are real issues. And of course, unfortunately, and some of the people are probably sitting there saying, yeah, I know about this, is sleep disruption, which can occur from either even just spontaneously, some people just can't sleep well, or there can be things like hot flashes, which are bothering folks. All these things can contribute to the sexual dysfunction and libido issues. So it's a very broad outline, number of problems that can be going on. And we're here to try to deal with all of them if we can help. Can we have the next one? So I'm sorry.
Did I miss the physical one? The physical slide, I think I must have missed it in the PowerPoint, but there are physical changes, things like scars, ostomies, ports, people who've had a mastectomy, people who've had prostate surgery, just physically have changes that can either be affecting their, ability to have certain positions during intercourse, ability to, maybe there's loss of sensation after a mastectomy that affects the breast as an erogenous zone, or maybe pain with certain sexual positions. So I'm sorry that I left that slide out, Dr. Minkin, but also the physical changes from cancer treatment then can certainly affect sexual function as well.
No question.
I would also add reconstruction in there, right? So with reconstruction, changes in anatomical changes.
Yeah.
And some of these things, there are problems, and we understand that what goes on in a typical visit, that, there are people are dealing with a lot of problems in a visit to the oncology follow-up folks. And so there's oftentimes a lack of time to address the sexual health issues and the complexities of cancer care. And sometimes providers, we're the guilty ones, because we say, well, the patients are going to bring up topics if they're dealing with issues of sexual dysfunction or menopause. No, if we've learned that if we don't ask, they don't tell oftentimes. I mean, some folks will, and God bless them, and that's terrific, and we love it if they do. But oftentimes people won't. They're embarrassed, and they're waiting for the provider to ask, and oftentimes they're not asked. And the other thing is, patients, men and women, may not feel comfortable discussing their symptoms. And there are multiple surveys that can be used. And again, one of the most unfortunate things is, and Elena alluded to this a little bit as far as, in the topic of, we're surgeons and taking care of people, that many, unfortunately, surgeons sometimes have the feeling, well, we operated on you, you're cured, that's great, that's enough. And, many patients feel guilty about, well, I really want to do a lot more with my life than, just having been cured of my cancer. And, they feel embarrassed, and they feel like they're asking for too much, and they're not asking too much. It's perfectly the right thing to do. do to be asking for a normal life afterwards. So that's an important thing. So I think on our next slide, we have a list of some of the ways to assess things. And there are guidelines to do this. There's documentation for people who have to have, a guideline to say, yeah, they're NCCN, National Cancer Survivor Networks. And we're supposed to, this is part of the guidelines, that we're supposed to ask about sexual function at regular intervals. And we should discuss issues about fertility, particularly with our young patients who are diagnosed early. There are plenty of screening tools out there. We'll talk about a couple of them, and you can adapt some of these yourself and bring stuff with your providers. And there are patients who will do well if they need to see a sexual health specialist, if the survivor is interested in it, and then make the appropriate referrals from the provider for therapy, couples counseling, sexual counseling, regular GYN care, urology, or a sexual health specialist. And we'll talk about some of them later. And then follow these things up, reevaluate at regular intervals. And this indeed is a survivorship guideline published just basically a year ago. So these are up to date and they're guideline driven. And these are the things that we're supposed to be doing and supposed to be asking.
And I would add here that we can certainly also consider a referral to our friends from physical therapy. And we
Absolutely.
have Denise here on the call as well. And Denise is one of the wonderful pelvic floor physical therapists at Smilow, who helps us with patients who have any challenges with the muscles and the complex anatomy of the pelvis. And she can help with a lot of the sexuality challenges that people have. So we can also refer to our physical therapist colleagues as well.
Absolutely. And we do regularly. And we do. And I was just thanking, for those who heard me thanking Denise for helping one of my ladies there that she's been very active in. Now, this is what I was alluding to before. And this is just some brief sexual symptom checklists, as you can see, they're for guys and for ladies. And so I'm going to focus in, because we're focusing in tonight on the women, but there are issues that men, certainly could well bring up with their providers. And for women, just a simple question: are you satisfied with your sexual function? I'm going to ask people listening. I won't ask for a show of hands right now. But, are you satisfied with your sexual function? Yes, no. If you are, okay, that's cool. That's terrific. But if not, how long has this been going on for? How long have you been dissatisfied with your function? And then what are the problems that you're dealing with? Because female sexual dysfunction has a whole bunch of areas, and this is not to deal with cancer survivors. This is just overall in female sexual function. There are folks who have issues with little or no interest in sex. There are people who have problems with decreased genital sensation, feelings. There are people who have decreased lubrication issues, women who have dryness. There are women who have problems reaching orgasm. There are problems with women having pain with sex, both with penetration, but also deeper on the pelvis. And which problem is the worst for you? Which one, if we could say, let's focus first on that one, which is the most bothersome for you? So we can focus in on working on that first. And then the next most important thing is, would you like to talk about it with your healthcare provider? And we hope you will, and we hope that we can be here to help. So those are just some simple things to maybe generate some thoughts, of people listening and watching, to say, maybe I could, deal with some of these issues. And that's what we're here. These are the issues we deal with every single clinic. I can't think of a clinic we've done, Johanna, that we haven't dealt with these issues.
Right.
This is called a day at Smilow here. Absolutely. Okay, now this just emphasizes a little bit some of the overlap that we're dealing with here on the management of sexual dysfunction. And there's input from everybody, because there are issues from the fertility particularly for our younger folks, issues of sexuality for anybody, because sexuality is a human problem, not a problem of younger or older folks or anything like that. And these are some of the folks that we may bring in as well to help deal with it. We may bring in a reproductive endocrinologist if we're dealing with, trying to do ovarian egg preservation, genetics folks, our mental health workers we've talked about. We have tremendous input from our psychologists. We also occasionally refer to a psychiatrist or a social worker. We have our GYN oncology friends with us. And then as far as Johanna alluded to already, pelvic floor PT is really important. We may refer to a full-time sex therapist, and we have ways to contact those people. So we can draw in all these people. And at the center of this is the patient, either herself or with a partner, without or with a partner. These are how we try to approach the issues, because they're all at play here. They always are.
And one of the most important things is that we know cancer survivors at any stage can have a partner. They can be dating, they cannot have a partner, and sexuality looks different to everybody. And we want to be inclusive of patients who have a partner, are looking for a partner and concerned about that, or even if you don't have a partner, it doesn't mean you're not a sexual person. So we certainly are happy to help you in whatever stage of your life you are.
Absolutely. Okay. And these are some of the psychological interventions that our team will work about. That, of course, there's grief and loss, which happens to everybody in this process, but we want to establish a new normal. This is where you are, and you're going to be okay. Trying to deal with anxiety and getting rid of negative patterns of thinking, to think about the positive way we're going to address all these issues. As Johanna talked about, ways to cope with dating and communicating with current or potential partners. Okay, this is a problem. I've had this. Okay, are you okay with this? And how can we make it okay if it's not? Relational issues that are there that can affect sexuality and intimacy. We want to facilitate communication among everybody, particularly between partners. We want to help folks develop relaxation skills to help make things more comfortable and get our partners engaged. And again, getting back to this new normal, embracing the new normal, to say, okay, things are a little bit different, but let's say this is okay, and make it better. And this is actually a book that Johanna hands out regularly to our patients. And it's just a little bit of a guide as far as some of the behavioral interventions we talk about. There are different lifestyle interventions that can happen. Just simple positioning with intercourse, that things can be better. And we can help guide people different positions they may not have thought about, given what's been done surgically or radiation therapy wise. Kegel exercises, it's very important. I love Kegel exercises. Everybody should do them. The guys should do them too. But anyway, we want everybody doing them. And of course, getting Denise and her team involved with pelvic floor PT. And the important thing, experiment and explore. Just keep trying different things. And, a person that I quote regularly, who I've had the privilege of working with, and Johanna knows who I've got to quote, is the esteemed Dr. Ruth Westheimer. And Dr. Westheimer taught me many, many things in my life. But one thing, if it's between consenting adults, it's fine. Whatever you want to do. Consenting adults at school, kids no, but consenting adults, yes. And so there's a lot of exploring to do and a lot of experimentation. And as long as you guys are both comfortable, that's terrific.
And this is really one of my favorite pictures to use in my job. And I've actually reached out to the American Cancer Society and gotten permission to use this picture and share this picture, because I think a lot of patients feel really uncomfortable talking about intimacy, even with us, but also with their partner. And this kind of helps. And you can find this on the American Cancer Society website. And we have some books about female and male sexual health and cancer. And I like this picture because it makes people feel probably a little bit uncomfortable, but it makes you realize that you can try different things. And if it doesn't work for you, that's fine. It may give you some new ideas, but hopefully it means that you can start talking about it freely and realizing that this is part of your health, even though it's a very sensitive topic.
Exactly. Absolutely. Now, I referred to this a little bit before, that are actually organizations. ASECT is one of the most important ones. And they have both certified sexuality counselors to work on, you see at the bottom, American Association Sexuality Educators, Counselors, and Therapists. And you can even look that up right now if you want while we're talking, to help resolve sexuality concerns, specific exercises, techniques. And there can be medical providers. There are a couple of people in town who are sex therapists and are, OBGYNs and medical folks. And then there are certified sex therapists who are mental health professionals who focus on sexuality, again, to assess, diagnose, and provide in-depth psychotherapy. So there are different folks around, and this is one way to get a hold of folks, and we can give you some advice when we see you in the clinic as far as different people to contact. This is one of my favorite slides. I love this slide. Johanna knows that. And these are some of the stuff that we talk about in the clinic from a point of view here. Medical interventions for women, we got lots of stuff available. Many women, for example, don't know the difference between a lubricant, which is something that people will use at the time of intercourse, or a moisturizer, which is something that we use on an ongoing basis, 2-3 times a week. Can be hormonal, can be non-hormonal. There are various medications which we can use. Those beautiful things that look like those little cylinders there and the pretty colors are vaginal dilators, among my favorite gadgets in the world. And we love to also prescribe sexual devices. You'll see a vibrator up top. And vibrators are great. And people think, oh, these are naughty. No, they're not naughty. And they have medical benefit because anything that will increase pelvic blood flow, and vibrators do, increases moisture, and moisture is good. So these are important things. The other things you see, by the way, up top on the left is a gadget that I was totally unfamiliar with until Johanna taught me about this. And this is called the O-nut. And so if a woman has a vagina that's been somewhat shortened by surgery or radiation therapy, and she's concerned about penetration, but her partner going too deep, this little gadget can be very, very helpful as far as limiting the amount of penetration, but basically so people can have good sex, even if they have a somewhat shortened vagina. So we got lots of stuff to talk about and to suggest for folks. And a simple thing that you'll see on the bottom there is a little bit of Novocaine, lidocaine jelly. And I try to sort of tease people with this because I'll say, you ever been to the dentist and gotten Novocaine? And people have these ideas of needles and stuff. And I like joke, no. This is a cream. And you can be very, very helpful for people who are having some pain with penetration with intercourse. Just using a little Novocaine jelly takes about 3 minutes to set up, and people can be a lot more comfortable with sex. And we will show them in the clinic how much more comfortable they'll be before we do a pelvic exam even. So lots of tricks that we have.
Mhm. And what you might find if you haven't taken a look in the boutique recently is that the Smilow boutique on the first floor near the atrium in New Haven has some of these things that you can ask about. And our Smilow boutique staff is very knowledgeable in helping you if you have questions about any of these, or they can give you some resources to help you find them.
Absolutely. Okay. And now I'm not going to go through all of this stuff, but this is from a scientific paper. This is from the scientific literature from one of the Menopause, an international menopause journal. And it's written actually by 3 friends of ours. Sharon Bober, who is a psychologist up in, even if they're from Boston, it's okay. And Cheryl Kingsburg, who's from Cleveland, and Stephanie Falbian, who's the executive director of the North American Menopause Society from the Mayo Clinic. So these are some good, substantial people. And how do you treat folks? Well, these are all things that we do. We offer education, counseling and sex therapy, lubricants and moisturizers, vibrators, dilators to help stretch the cervix, pelvic floor physical therapy, just showing these are acceptable therapies in the scientific literature. You can have the next slide there, Joanna, to go on the rest of the stuff here.
Yep. Denise, do you want to talk real quickly before we move on about what types of specific therapies you do, or do you want to do that at the end?
Either is fine. We could probably wait till the end because it could be a little more extensive.
Yeah, so we'll have Denise give us some more specific pelvic floor techniques.
Okay. And then just to some of the particular products that we use, these are different vaginal estrogens, which are really quite safe for almost everybody who's had a tumor. Most, not a few people who can't, but most people can if we need to. So these are different forms of vaginal creams, suppositories, rings. And then we talked a little bit about the lidocaine and the Novocaine. And there actually is one oral medication, which is listed here as a serum, which is called ospemifene or Osphena. And this is actually a sister drug of the drug tamoxifen. Which the tamoxifen doesn't really help particularly moisten the vagina, but this drug happens to. So very, very clever molecule here. So we got a lot of options that we can use for folks. So don't say, oh, I had this or I had that. No, we can use it. And this is just a slide I throw in here because even systemic therapy can be okay for many, many women with cancer. No, we're not going to put a breast cancer survivor in general on systemic estrogens, but people who have hematological malignancies, people who've had different leukemias or lymphomas, colorectal cancers, cervical cancers, vulvar or vaginal cancers, these folks can take pills or patches of estrogen. So they can do very well with that. And there's low dose vaginal estrogen for localized symptoms for just about everybody. And then for people who have the hot flashes and stuff like that, we tend to go with the systemic type stuff if they are a candidate for it. So we got a lot of options out there, folks. Don't cut yourself off from thinking about different things that may sound, oh my goodness, yes, we can do it. Okay. So, and this is just a list, and we'll go over these with you. We give handouts like this regularly as far as different organizations, which you can look up online. And these are reliable things. Now, I'm not saying Dr. Google isn't reliable, but there are certain things that sometimes people will come in saying, well, maybe that's not quite true. These are pretty much reliable sources there as far as options. Yeah, okay. So I think with that, I think that's our last slide for folks there, Joanna, I think. Yep.
Yes, it is.
So, Elena, did you want to say something now?
No, Mary Jane, I think you did such an amazing job as always, discussing these issues. And I think the most important thing is just we open this communication and we have this conversation, because really nothing is more important than acknowledging this and appreciating that there's room for conversation and there's room for acknowledgement, and then there's so many things that can be done. There's so many options. I think the thing that breaks my heart the most is when our patients say, well, I didn't bring this up because I didn't think, one, I didn't think this was a problem. Two, I didn't think anything could ever be done. And I think that's the important thing, that we acknowledge that this is something that our treatment does to women, and that this should not be accepted. It is not okay to live like this. There's many things that can be done, and this has to be addressed from every single direction. And we're here for you, and many other providers are here for you. So we very much would love to open this conversation, and we're open to any questions.
So our first question, and I'll ask Dr. Minkin to weigh in on this, or Denise as well. And then we do want to still have Denise explain some of her therapies as well. But let's do one question first. When you use a dilator, Dr. Minkin, if it hurts or you have some blood on the dilator, what should we do? And does that mean that it's dangerous, or we should be a little more forceful in pushing it harder if it feels like it's stuck?
Excellent question to whoever asked that. Okay. And a couple of things. Number one, what we will do is oftentimes have people come to the clinic. And it's hard to do this on telehealth. I will say we've had some tricky times thinking about doing it on telehealth, but that's why we like having folks in person for these kind of issues. That bring your dilators with you so we can work with you and let's do some show and tell and see what's going on. Okay. Much of the time, if it's like stenosis, that the radiation and stuff like that has been a problem, that we can help moisturize the tissue to make it stretchier. Okay. And if you're somebody, which is really most everybody who can use, for example, some topical estrogen cream. Okay. We oftentimes will use a little estrogen cream, have people rub the estrogen cream with their fingers, or in my terminology, smear it around. I never write that on a prescription, folks, but I just tell you what to do. To take some estrogen cream, smear it on that area, do it daily, every other day, whatever, until we get that tissue softer and we'll have more give. Okay. And then we'll work on oftentimes using a little bit of Novocaine when you're actually working with the dilators, because that'll make it more comfortable for you, so it doesn't hurt. And then starting with a little tiny dilator and working its way up to help stretch that tissue. And it will go most of the time. I mean, we really can have great success most of the time. And the example I tell everybody with dilators is that there's a condition, fortunately, it's very rare, but it's a condition that young girls can be born with, that they have no vaginas, that they're born without a vagina. And using dilators, they can actually manufacture a vagina. They can stretch that tissue to make a vagina. So that area has a good amount of give if we can just get to it. So that using estrogen creams, a little bit of Novocaine, gentle dilatation, these things can work. So, can I say that it works for everybody? No, but we have pretty good success rates. Joanna, can I turn that over to you?
Yeah, and absolutely. If there's bleeding that you're concerned about, please call us. You can, pop into the clinic on a day that I'm there. Even if Dr. Minkin's not there that day, you can come in. If I'm available, I'm happy to take a look and see if sometimes breaking up the scar tissue, especially people who've had radiation, just breaking up the scar tissue can cause some spotting or bleeding, and it can be pretty scary. So if you feel like something might be going on, you would like us to take a look, we're certainly happy to do that.
Yeah, come in and do it with us there. So, we'll give you the, hopefully the confidence to say, let's take care of this. And there isn't anything we can't take care of there. As far as you got bleeding, we'll fix it, don't worry.
And Denise works with the dilators too, and she's excellent in helping the women. So Denise, do you want to share a little bit?
I was going to jump in. So two things that I think were missed was lubricant. So certainly making sure that things are gliding well. Because I agree, the tissue is pliable and will start to conform, kind of like, you know, clay or something that you can kind of work to slowly and gradually mold it. But also position, I think, makes a difference. You know, thinking about the anatomical position of the hips, the diaphragm, and you know, from a PT perspective, abdominals. So, you know, are we gripping or tightening the abdominals because things aren't feeling comfortable? And so, you know, just by working on expansion of the diaphragm, can we also be mobilizing the pelvic floor? So, you know, if we're holding our breath because we've experienced pain, and, you know, subconsciously or consciously, we know from experience that this penetration can be uncomfortable, you know, are we kind of biasing the situation? So certainly not from the blood perspective, but you know, situationally, if we've had pain with penetration in the past, or even most recently, could our mindset kind of be contributing to that? So working on calming the central nervous system, working on making sure that the tissues that surround the pelvis, whether it's the abdominals, the glutes, the adductors, all of these muscles are moving and helping to kind of mobilize this area. And then positionally, you know, how are my hips positioned? So could that be influencing or kind of shutting down or closing the vaginal canal? So can I move those to kind of help to influence the mobility of the tissue? So yeah, I think it's looking at it, you know, from my PT brain of like, how and what is going on, and how can I influence this or modify these situations to kind of make things feel a little bit, you know, more easy, and work smarter, not harder, essentially.
Yeah, and some women, that's a great point, Denise, is what are the angles that we're looking at here? And some women would be really surprised that if you're lying flat and try to insert the dilator straight towards your head, you'll probably hit your pubic bone or your urethra, which is you know, where you urinate from.
Exactly. Knowledge is power, right? So the vaginal canal kind of comes posterior. So, right, you certainly want to avoid 12 o'clock, right, the urethra, and then, you know, kind of pointing the dilator or whatever penetration device you're using towards kind of the spine will certainly help to kind of guide things along. Agreed.
Yep. So I usually tell women, if you're lying in your bed and you're using the dilators, point the dilator toward your bottom or toward the bed, as opposed to towards your head.
Right. Right.
Yeah. Are we ready for another question?
Sure.
So another question from one of our visitors here, Dr. Minkin, thank you. You saved me during chemo when I had a lot of dryness. But do you have anything for libido? Is there anything new out there for sex drive? Because it's hard to get that sex drive back.
It is hard. You know, there's no question about that. And that's the trickiest thing of all. And again, this is something that's tricky. You don't have to have had cancer to be dealing with this decreased libido. Unfortunately, it's a very, very common problem that women face. The key thing, the first thing I say is you got to be comfortable. So even again, and somebody who's not had a cancer diagnosis, patient of mine just comes for a routine checkup, but she says she's got no libido. I'll say, well, what about, you know, if she's postmenopausal, what about your vagina? How comfortable is it? Are you having pain? And she'll say, oh yeah, I have pain, but that's not what's giving me the problem. It's like, yeah, it is. Because the other thing is, I don't want people to want to have sex if it's going to hurt. That's not a good thing either. So what we usually like to do is to try to get the vagina comfortable. Let's moisturize and stuff like that. Now, sometimes that'll just do the trick. Sometimes people will come back, well, it's totally pain-free, but I still could care less. That's a different story, okay? And the issue that we're dealing with libido is for premenopausal women and women who are postmenopausal. I know it sounds crazy to divide it, but actually there's one medication, I shouldn't say medication, herbal preparation that we've started using in the last couple of years pretty widely, and this is new, this is a new one, is something called Ristela, Ristela. And that's an interesting compound. It's available over the counter. It is not hormonal. And what it basically does is it increases the production of nitric oxide from the medication itself, or the herbal product itself, which increases pelvic blood flow, which will increase moisture, which is a good thing too, but it'll also your blood more juices flowing in the pelvis. You'll think more about sex. And we've had reasonable results with it. And that can be used in premenopausal and postmenopausal women. It is not hormonal. Just about everybody can use it. So we use that fairly commonly. And that is a fairly new product. It's been in Europe for a number of years, just came over here a couple of years ago. As far as other medications, one of the things that people have now gotten to the point of accepting is the fact for postmenopausal women that testosterone can be helpful, and particularly for women who've had their ovarian function, either the ovaries are out or their ovarian function has been stopped by chemotherapy or whatever, that they are dealing with lower testosterone. And that indeed, as long as your tumor was not a hormonally influenced tumor that testosterone could be contributing to, then we should be able to use it. And so, and it's a sort of a strange thing. It is legal in the United States to use it. It's not commercially available, but we have our ways and sources of getting it. So that's not a problem. And so testosterone has come on the scene as being an acceptable therapy and advisable therapy for people with postmenopausal decreases in libido. For premenopausal women, actually, if somebody's got intact ovarian function, we wouldn't push testosterone. But if somebody who's had her ovarian function taken away, then testosterone is totally reasonable. And there are a couple of other new meds out for premenopausal women out there, which are one is a medication that basically both designed to increase libido. One is a pill that you take every day. And the other one, believe it or not, is an injection. It's like an EpiPen, don't get nervous, that you can actually inject with about like an EpiPen 45 minutes to an hour before you want to have sex. So you say, I want to have sex Saturday night. Okay. Pop yourself this little injector. It's called Vyleesi. And the success is reasonable. So we got a lot of little tricks that we can use there. I don't think we and many of these are new. So we have some newer tricks out there.
There are also a lot of things you can find online. We do have some certain websites that we tend to like that are a little bit more medical based websites, but have different stimulating oils and gels, some toys and games, some different things for partners as well. Vibrators can be helpful for foreplay and stuff like that. So if you need a little bit of a head start, or if you have a birthday coming up, you want a gift, we can give you some of those websites to look at. Denise, another question from the group is, what do you recommend for lubricants? Do you usually recommend water-based or silicone?
Great question. And I think it depends on the patient. And what you're using it for, or with or for. So oftentimes I'm kind of currently on oil-based lubricants, actually. There's one in particular, emu oil, that tends to be very helpful for people. But if you're using it with a so technically you're not supposed to use it with a dilator because it can penetrate the silicone surface. So cleaning wise, it's not recommended. So if it's intercourse based kind of penetration without a tool or toy, I would recommend usually a water-based otherwise a water-based lubricant or a silicone-based lubricant, just depending on personal preference and how it feels for the patient.
Yeah, and there's another question too about lubricants for people who have an estrogen sensitive breast cancer. And so, again, it's really important to feel comfortable with what's being recommended. So we do know that, in many cases, even with estrogen sensitive or estrogen positive breast cancers, we can try a low dose of a vaginal estrogen because, again, it's a local medication. But for women who say, I just don't feel comfortable, I don't want to start with that. And oftentimes we don't start with estrogen. We start with something called a vaginal moisturizer. And so you think about, lubricants are really good at the time of intercourse or when you're using your dilator and you just need a little bit of extra moisture. But sometimes we recommend vaginal moisturizers for regular use. And there are a couple different ones on the market. Some are little suppositories that kind of melt inside, and some come in gel forms. You can get these over the counter, and none of them have estrogen because they're non-prescription. But a moisturizer is good, just like you moisturize your skin after you take a shower or when you wash your face at night. You can actually moisturize the vagina. So there are a couple of different ones. Some are hyaluronic acid, which you may see in the face creams that are out there these days. And there are some other that are aloe based. So there are different types of moisturizers, and those are for regular use. And we usually recommend 2 or 3 nights a week to use the moisturizers, and probably best to do it before bed because they can sometimes leak out. And so if you put it in the morning, you're walking around all day, you may feel a little leaky or like you have some discharge. So if you use it at night, with your body heat at night while you're sleeping, it tends to kind of melt into the vagina, get into those vaginal tissues, and really moisturize. So I hope that helped.
Absolutely. Perfect.
Dr. Minkin, can we ask another question?
Of course.
Can you talk a little bit about urinary symptoms that may happen for cancer patients and survivors, and how do you figure out if it's a urinary problem? Should I see a urologist? Is this a medical issue, or is this a menopause issue? How do you know the difference?
Well, I always think it's a gynecological issue for everything. So that's my answer, of course. That couple of things that so basic biology is that the tissue that lines the vagina is very similar to the tissue that lines the bladder and the urethra. They're derived from the same, when we're in our mommy's tummies being formed, they're derived from the same kind of tissue. So it's not surprising that the bladder tissue and the urethral tissue responds to estrogen or the lack thereof. Okay. So anything that basically will lead to a decrease in estrogen levels will oftentimes lead to bladder problems, which can be a real issue. So in general, if somebody's complaining of bladder issues and discomfort, and they may be complaining of pain, frequency, incontinence, recurrent urinary tract infections, all the above can be related to a loss of estrogen in that tissue. And the key thing to remember is, again, fortunately coming back to biology, that indeed the bladder and the vagina are attached to each other. Okay, when Dr. Ratner does those surgeries on you to take out your uterus or something like that, that she actually has to peel the bladder down to take it off of the uterus to do the surgery. So that's, it's really close anatomy there. So in general, what I will often do is if somebody's got any of those urological symptoms, if they are a candidate for vaginal estrogen, I almost always think it's worth a trial to get some vaginal estrogen. We can't put estrogen right into the bladder. It's too tricky, but we certainly can put it into the vagina. And again, as long as somebody's okay about using it, and that will permeate its way up to the bladder and to the urethra and make the tissue healthier. The other thing that happens is, again, when the vagina gets dry, you end up, believe it or not, with nastier bacteria hanging around there. And when you have a bladder that is sort of weaker because of the lack of estrogen, and there are nastier bugs hanging around there, nastier bacteria, which can invade the bladder, you can end up with some pretty nasty urinary tract infections. So basically, that I'm a great believer if somebody is able to take estrogen vaginally, to use it, because I think it will help the bladder symptomatology in many, many conditions. Now, sometimes it's not, okay. Sometimes that you'll have the patient still dealing with symptoms, and then we may have you see a urologist or a urogynecologist. We have, several folks at Yale who are quite good, as far as dealing with these issues. But I almost always think about using some vaginal estrogens first.
And I think it's another important thing to know that, if there's something that you can't figure out, or your community provider, your primary care doctor, your primary gynecologist, there's just something that doesn't seem right, you may want to go back to your oncologist and just ask, is this anything related to my cancer? Could this be an issue from my hormones or my treatment? And then see if they can, of course you can come to the Sim clinic, but it's hard to know sometimes whether, a symptom is from a cancer treatment or if it's a symptom that anybody in the community can experience. And so asking, going back to your treating oncologist and saying, what are your thoughts on this? If your general PCP just can't seem to figure something out.
Right. And one thing I will put in my sort of shameless self-promotion mode, I've been good. I haven't said it yet, Johanna. I'm doing fine. That I will encourage everybody to go to my fabulous website, which is Madame Ovary, French spelling MADAMEOVARY. Well, that's not French, but anyway, madameovary.com. And on my exciting website, we have some nice videos for menopause for cancer survivors. And I now have come into the 21st century. I have podcasts. So if you would like to listen to a dry vagina podcast or a sexuality, intimacy, and menopause for cancer survivors podcast, come on over, listen to them, and hopefully it'll answer some of your questions for you, and then maybe generate some more questions that we could answer for you at Sims. Thank you, Heather. Thank you. My shameless self-promotion here. Yeah, click on it. Look at all the exciting things you can watch.
So I want to, Dr. Ratner, I don't know if you have thoughts or things you want to add.
I just think that we are so blessed to have the three of you ladies doing this in our community. I think we take this for granted and we don't as much appreciate what a difference you make by the care that you provide. And this is very much something that I'm so proud of to be part of Smilow, because we don't just treat cancer, we truly treat women and we think of women, and we just want you ladies not just to be cancer free, but also to be happy and have your lives back. And this is all that all of us are trying to do. So thank you to the three of you for everything that you do. And again, we're so grateful to be part of this community.
Thank you for making the trouble to get this started there, Dr. Ratner.
Yes, and Dr. Ratner for starting the program. And I think that this is so important for our patients and also for the partners. And we, in the Sim Clinic, we certainly welcome partners to be part of the visit, be part of the conversation. And I think, for the men out there, for the male survivors, ask your oncologist if you're struggling with issues. The biggest, male cancers that cause sexual challenges are prostate cancer, testicular cancer, colorectal cancer for men and women can be really challenging. And a lot of it can be emotional, but also physical changes. And for men with prostate cancer, there can be hormonal changes as well. And physical changes from surgery, radiation, chemotherapy. Anybody getting chemotherapy can have nausea, fatigue, hair loss. Even hair loss can really cause, changes in your self-confidence and how you feel. Whether you're with a partner for many, many years or not, it's normal to feel like you look different. You may be a little shy. We deal with all of that. We have great psychology folks who will help you be able to have the conversation with your partner. A lot of partners are also worried. Your partner loves you and is worried about hurting you or causing any pain or not wanting to, have intercourse with you if you're in pain or if you're tired or if you just don't feel well. So, we want you to be able to feel comfortable with your partner and talking about it and having these difficult conversations. And even if it comes to finding different ways to be intimate, if it's, going on dates again or holding hands and cuddling, watching a movie, we're here to help you get back to whatever your intimacy level that feels right for you and your partner. So, we're always happy to meet you where you're at, try to, help you find new things that work for you and support you, in medical ways, but also in emotional ways and psychologically as well. So we're here for you. We're here for your partners. Men, we can help you. We'll just find you the right people to go to, because for males, there are different procedures that can help. There are medications for men. Some men get hormones as well as women. So, I know there are some men on the call here, and I don't want you to feel that we're, neglecting you, but we can certainly point you in the right direction.
Absolutely.
And I just want to add, quality of life is just equally important. So it's fantastic to survive and to continue on, but the quality of life is, what we've been talking about. And I think that's just really equally as important at a certain point is, feeling like you are there and able to do the things that you want to enjoy. And, you know, as a PT, my perspective is all about function, right? So being able to function in the way that you want, and you know, you guys have said that already, but I just think it's important to echo, because you know, you've done a tremendous job already, and now, you know, it's time to kind of get back to the things that you want to do, and a relationship is a huge piece of that. So, you know, thinking about how all of these different symptoms are affecting, and kind of putting all of these puzzle pieces together. And I always say that a multidisciplinary team approach is kind of the best way to find all of these different pieces and make sure that they are whole again as much as possible.
Excellent points.
We have a great question from an audience member about somebody who's had lymphoma, Dr. Minkin, and has a stem cell transplant. Should there, you know, what might be the consequences of that, and is hormone therapy safe if needed?
That's an outstanding question. And the answer is that's actually one of my archetypical ones that I say these folks are great candidates for hormone replacement therapy. Because particularly if we have somebody who's young, who's had, and much of the time she will have had chemotherapy before she's had her stem cell transplant. So her ovarian function, you know, has been is not there at the moment. And we are concerned because we want these folks to lead normal lives afterwards, totally normal lives. And we do know that if we don't give these folks estrogen, they may end up with some increasing problems of bone loss or heart disease or cognitive issues. These things are very important. So we actually do recommend hormonal replacement therapy for most of these folks. And the answer is it's quite safe, will not encourage a secondary malignancy. So, which is the question, you know, does it encourage GYN malignancies? No. If somebody's got her uterus in place, we give progesterone when we give the estrogen to balance it out as far as stimulating the lining of the uterus, but it's certainly quite safe to give. Now, one thing we do tend to use a little bit more in our program than maybe in the general population. And some people are concerned about blood clots with certain, you know, having had certain cancers. So we can minimize that risk very nicely by using a patch, by using a transdermal estrogen. And we use a lot of transdermals. We don't use exclusively transdermals, but so we can basically minimize the risk of getting blood clots by using a patch of estrogen. And we have lots of those folks on estrogen therapy, so not a problem.
Great, thank you. Do we have any more questions from our, this has been a wonderful audience.
Yeah, it's great. We got lots of excellent questions.
Some great questions from you.
Hi.
How about Dr. Minkin, if there's a great question in the audience, I haven't had any hormone replacement and it's been 10 years now, and now it's becoming more uncomfortable and I feel more dryness and what we call atrophy. Is it too late to start any treatment for that?
The answer is absolutely not. Vaginal estrogens we can start at any point, you know, okay? And that dryness tends to be just a function of time away from estrogen. The tissue gets drier and drier. But the vagina is an amazingly forgiving organ. It's wonderful. It's a fabulous organ. What can I tell you? And that you start using vaginal estrogens, we can make anybody have a really great vagina. So, well, she'll make the great vagina. We'll give her the medications. So, but the changes are pretty much reversible, and that women can regain really normal vaginal function. And sometimes they may need a little dilator therapy to help if things have gotten a little narrowed, but we know how to use dilators and we can get these folks using dilators. So the answer is no, we can fix the vagina. The controversy actually would be as far as putting somebody on systemic estrogen. If she hasn't been on systemic estrogen patches or pills for 10 years or more, then there may be some questions, not some more esoteric questions about heart issues and stuff like that. But as far as vaginal therapy, no problem. Come visit us. We'll start you tomorrow. No problem. Well, I guess next week, whenever we have clinic. But, well, you know, vaginal tissue is very, very fixable there.
Yeah. And one thing I think that is worth learning is that, you know, what exactly is considered menopause? And so in the cancer population, it's actually a little bit unique in that certain therapies, like chemotherapy, can put somebody into a temporary menopause. So what does that mean? Well, young women on chemotherapy, their ovaries kind of shut down, and during chemo, they stop having periods, they have the hot flashes and night sweats. And then once their chemo is done, at some point, sometimes the ovaries kind of wake up again. And so, that can be a temporary thing. In natural menopause, or if somebody has menopause from surgery or radiation, which tends to give more permanent menopause, the hot flashes and night sweats can be temporary. For women, we think about that naturally happening around age 50. Some women have hot flashes for a year. Some people have them for 5 years. Some people don't get hot flashes at all. The vaginal symptoms, though, tend to be more long lasting. And those can also be added on to if somebody's had radiation, for example. Even if the radiation was 10 years ago or the menopause was 10 years ago, the vaginal symptoms can tend to be more long-term and actually worsening over time because it's been that long without getting estrogen to those tissues. Same with the urinary symptoms. So, even though certain symptoms of menopause can be, temporary and stop, the vaginal symptoms, dryness, pain with sex, tightening of the vagina that we call stenosis, scarring from radiation tissue, those can unfortunately get worse over time if we don't manage them and try to work with you a little proactively.
Excellent.
So we've had some great questions. We encourage you to reach out if there's anything we can do to help. If you'd like to connect, we can connect you with Denise. I will actually, while we're closing up here, I'll provide our clinic website so that you can find us. And I'll let you close, Dr. Minkin, if you'd like.
Well, I would say echo Joanne's sentiments, which I usually do. She said it better than me. But, we're delighted to have the interest to have people, visiting with us tonight, asking great questions. And we're here for you. So you have any questions or problems. And the other thing is, we know there's great community in cancer survivors, which is wonderful. I mean, people supporting each other, which is terrific. So if you have a friend who's having some issues and saying, gee, these are problems that I've been dealing with, send her over. We're happy to see folks. And, we have a lot of people who come in referred by patients, my friends, Susie. Oh yeah, we know Susie. And, that come on over, and, we want everybody to be good. And as you can see, Joanna's just sending a message here as far as how to get a hold of us and to learn more about the program, and come on visit. And we're happy to help take care of you.
And we are doing telemedicine too, even though unfortunately, we can't do good exams. If it's something that we can try to help even without doing an exam, and oftentimes we don't do exams in our visits, because if you have dryness, we know you have dryness, and we don't always need to take a look. So we can try to figure things out over the video if you live far away. Right now, we are doing telemedicine, video visits with Zoom, phone visits as well. So we're happy to see you in whatever way works for you.
And sometimes, because of work schedules and stuff like that, sometimes it's easier for folks because of work schedules to do a Zoom visit, and it may be easier for them to incorporate their partner as well. If you want, and sometimes you don't want your partner there, and that's fine. We understand those issues too, but you want to be there with your partner. A video visit may be helpful for you, maybe a time saver for coordinating schedules and stuff. So whatever works, we want to do it.
And Denise, you're at a couple different locations, I think, right?
Yeah, so we have a team of pelvic PTs actually across the health system. So from Greenwich all the way up to Westerly. And I myself am in New Haven, so Yale Physicians Building. I see patients at our Guilford site next to Bishop's, and then all the way up to Old Saybrook. And then we have Wendy Price actually just returned, who is at our Smilow clinic, and then she's going to split her time down in our Milford clinic as well. So that's kind of Yale, New Haven centric, but then we have people across the the Gold Coast as well. And we are also doing televisits or virtual visits and in person. And again, you know, I do a lot of hands-on work, but it really depends on the person, their comfort level, and kind of what's going on. So it's not something that is, you know, forced on someone. It's really dependent on symptoms and need at the time.
Well, thank you for what you do for our patients. It's just wonderful and helpful, and it's helpful when they don't have to always come down to Smilow as well.
Right.
Yeah. Thanks for having me.
Thank you for being here.
All right, well, thank you so much, all of the panelists. We are so appreciative of your time, and ladies, we're so appreciative, and men, we're so appreciative of everybody being on this call and being part of this conversation. And we're all available to you, anything we can do to help. So thank you so much to everybody. Good night.
Thank you all. Thank you very much.
Night.
Good night.